opinion. It's telling you which way to go. This is where you can use a family history. If the LDL is, say, 130, you can use CRP. Or if they have a strong family history in the 50s and 40s, you can say, look, your family history, I would recommend it. This is where you use an ankle brachial index to help sway you one way or the other. And this is where you use a calcium score, but that's a little more expensive. So the intermediate risk patient, if they have a high family history, put them on a statin. I mean, you all should remember the Jupiter trial, a landmark trial. Patients had an LDL of 130. So what they did was they checked the CRP. If the CRP was high, they took those patients and they put them on a statin versus placebo. And there was a significant reduction in major cardiovascular events in patients who had an LDL of less than 130 and an elevated CRP. So the guidelines basically say if the CRP is less than 1, the patient is low risk. If it's more than 3, they're high risk. If it's more than 1, which is in between, repeat it in 2 weeks, see if it's still persistently elevated, then you'll know they're at higher risk. So the CRP helps you for the intermediate risk patient, especially if they don't want to take a statin. Okay.
Which one of the following scenarios is best defined as hypertensive emergency? An asymptomatic patient with a blood pressure greater than 220 by 120 millimeters of mercury. Number 2, any blood pressure higher than 180 by 110 millimeters of mercury. Number 3, those situations which require immediate blood pressure reduction to prevent or limit end organ damage. Or number 4, those situations where it is desirable to reduce the blood pressure within a few days.
Not giving you a count.
It's not giving me a count.
Are you guys typing in?
No count.
Let's see if it works. It didn't give us a count, but we'll see what you chose. Okay, I have a little computer glitch. Oh, now it's counting.
Now it's going.
So basically what Dr. Mufti is asking you here is to differentiate a hypertensive urgency from a hypertensive emergency. All right, let's see what we have.
So, from the limited responses we had because of the glitch, it seems as though you chose 3. However, the correct answer is not even that one. The correct answer actually is 3, which is those situations which require immediate blood pressure reduction to prevent or limit. So whoever answered that is correct. And the difference here is you need to understand the difference between hypertensive emergency and hypertensive urgency. Urgency is the one where they come in, the blood pressure is elevated, but they have no signs of end organ damage. They do not have any unstable angina, there's no acute renal insufficiency, there's no hypertensive encephalopathy, there's no proteinuria in the urine if you check a UA. So that, if they do not have any of those signs, that is urgency. And you can treat those within a few hours to a few days by slowly decreasing the blood pressure. You can see them in clinic, give them clonidine, send them home, bring them back in a day or so to recheck the blood pressure, make sure they're going down. However, if they come in with any signs of hypertensive emergency, if they're coming in with chest pain, if they have acute renal insufficiency, if they have mental status changes consistent with hypertensive encephalopathy, those are the ones that need admission to the hospital. They need to be preferably monitored in an intensive care setting, and their blood pressure needs to be controlled. Not drastically drop, because you're going to cause a risk for a stroke because of the drastic drop in blood pressure, but slowly drop it. So those are things.
That's a very important question, because patients go to the office, they're asymptomatic, the blood pressure is 190, and they sent to the ER. So that's a hypertensive urgency. It's not an emergency. Okay, next question. A 58-year-old man with a history of type 2 diabetes, hypertension, and hyperlipidemia has a 10-year risk of atherosclerotic cardiovascular disease by the pooled cohort equation is 10%. LDL cholesterol is 128, HDL 44, he's on aspirin, lisinopril, and fluvastatin. Which of the following is the most appropriate statin management? Okay, again, pooled cohort risk. This time the patient's score is 10%. So we know less than 5%, it's low risk, 5 to 7.5, intermediate risk, and the high-risk patient is more than 7.5%. This patient is 10%. And we're having problems with the response system. Okay, I'm going to move forward. The answer is switch to atorvastatin 40 milligrams. So let me go over this again. The high-risk patient, there's one slide, is this incorrect? Okay. This is when we do last-minute stuff. Statins. High-intensity statin should be for the high-risk patient. That's what the guidelines are telling us. If you have a patient that's high risk, who's high risk? Number one, we told you anybody whose score is 7.5% or higher is high risk. Number two, anybody who has any vascular disease, carotid disease, coronary disease, peripheral disease, they're high risk. And anybody who's got an LDL greater than 190 milligrams, they're high risk. So right off the bat, the recommendations are for high-risk patient to be on a high-intensity statin. So atorvastatin 40 or 80 and rosuvastatin 20 to 40. If the patient is moderate risk, you can use a moderate intensity statin, the simvastatin, the fluvastatin, the pravastatin. But again, remember, there's a black box warning for simvastatin 80 milligrams. It is not recommended because of muscle injury. So the FDA has a black box warning on simvastatin.
Which one of the following factors is the main advantage of radial artery access for cardiac catheterization? Easier cannulation of the coronaries, lower risk of bleeding and major vascular complications, easier access to bypass grafts, or lower risk of peri-procedural myocardial infarction.
It's not working.
It's not working.
Okay.
Wow, we should. All right. So the answer is it has a lower risk of bleeding and major vascular complications. Now, as recently as 2007, there were about 3% of cases in the United States were via the transradial approach. Now, this was actually, if you look back, I'll show you, this is how it's, I'll get the pointer up here.
So, not an easy mouse.
Not an easy mouse to use, yeah. So
in the blue.
In the blue in the first picture right there, that's a catheter in the radial artery. This is the left radial artery here. So that's how you get access. And then closure is via a transradial band or a TR band to achieve hemostasis. So that's how you achieve vascular closure. However, if you look back, and I'll come back to that slide. If you look back, radial artery access was actually initially started back in 1992. And there was a vast increase in it with the initial enthusiasm, as indicated on the lower graph right there, until around 2000. And then it dropped off all of a sudden. And the reasoning behind that was, at that time, vascular closure devices were introduced. So that's the stitches that we put in when we go in from a femoral approach, or a star close device, or anything to close up the artery that prevents the patient from laying there for 6 hours, 6 to 8 hours of bed rest, or have a sandbag in place. So when that came in, the radial artery access took a hit, and everyone went back to femorals. But when the femoral artery approached, they realized that they were having a lot more vascular complications. There's a lot more bleeding. It's harder to compress the artery in the femoral site than it is the radial, because the radial, you put your hand on it, and right there you can compress right against the bone. So when that was noted back then in around 2007 is when we've seen a rapid growth in radial artery access. And the percentage of total PCIs, or interventions, that are performed via the radial approach was back in 2007 was 1.18%, and that was mainly in the Northeast. That has actually improved in the last quarter of 2012 to 16% of all interventions are performed via the radial artery. However, that is still mainly in the Northeast and the east side of the United States. It hasn't made its way all the way out here to the west. But if you look at this slide, this is the major study. It's called the RIVAL study, and it compared radial artery access to femoral artery access. And if you look at the total, and this was, if you look at the percentage of total stents procedures performed in the U.S., back then it was less than 4% were performed radially, when greater than 95% were performed femorally. Bed rest is 0 hours. You put a TR band on, you achieve hemostasis. While with femoral artery, even if you close the artery, you still have to wait 2 to 6 hours of bed rest. The success rate was the same, 95% from both sites. The one drawback of the radial artery is the need to switch. And that's where they have to be evaluated. The patient has to be evaluated if they are a candidate for a radial artery procedure. As you age, the arteries up in the shoulder get a little more tortuous. It's harder to cannulate the coronaries. Some people, you have to do a certain test to make sure they have adequate blood flow to the arm, which is called the Allen's test, which you occlude the radial artery and you see if there's adequate blood flow when it's occluded to actually perfuse the arm. So if they're ideal candidates, that might be the way to go, because the main issue is the major vascular complications are lower with radial artery. It's 1.4 to about 3.7%. And then, above all, patient satisfaction. 90% of patients who received the radial artery access, they loved it. 50% with femoral artery. So that's the main thing.
Okay. We don't have the response system, I think, but otherwise I would have said 100% should get this question right. An ankle brachial index of 0.3 indicates no significant peripheral arterial disease. True or false? Shouldn't take up too much time. And the answer is false. Now, I'm going to beg to differ a little bit with Dr. Block earlier, because he said he doesn't like the ankle brachial index. Now, he's got a point, but I'll get to that. Why should we use an ankle brachial index? Very simply because it is a universal language. If I call you and I say a patient has 100% stenosis of the peroneal artery or the profunda artery, most people don't understand that. But if I say a patient has an ankle brachial index of 0.2, we know that that patient is at risk of limb loss. So you should do an ankle brachial index. Blood pressure in the ankle is 120, blood pressure in the brachial is 120. You divide it 120 over 120 is 1. So your normal ankle brachial index is 1. If it's 0.9, they have some PAD. If it's 0.8, they have more PAD. If it's 0.7, 0.6, moderate PAD. When it's less than 0.5, or it's severe PAD, and it's 0.3, 0.2, it's critical. So who needs an ultrasound? An ultrasound is for the interventionalist to know the site of occlusion. So he knows how he's going to approach it, when he's going to approach it. All you need to say, hey, listen, your ankle brachial index is 0.3. You're at very high risk. So where are the limitations that he was talking about? If your ankle brachial index goes up, if it's 1.2, 1.3, 1.4 especially, that's false, and that also indicates a high risk, because when you put the blood pressure cuff over the ankle, you inflate the cuff. The vessels are so calcified in diabetics and in patients with kidney disease that you cannot compress it with the blood pressure cuff, so you get a falsely elevated ankle brachial index. Those are the patients you can go on to do an exercise ankle brachial index, and all you got to do is just make them stand on their toes up and down for about 10 times, and you measure it, and if there's a 20% drop, then that patient has significant PAD. Or nowadays, all of the machines give you a toe brachial index, and for some reason, the toe vessels do not get calcified. So the toe brachial index of less than 0.7 indicates significant PAD. So it's a universal language, everybody understands it. So an ankle brachial index is very important and easy to measure. Okay.
Which one of the following statements is true regarding the thrombin inhibitor dabigatran or Pradaxa? It is indicated for prevention of stroke in non-valvular atrial fibrillation. It is indicated for prevention of stroke in patients with mechanical heart valves. It caused more life-threatening bleeding than warfarin, or it caused fewer GI bleeds than warfarin. Everyone should get this right because they did discuss this earlier. We don't have the response system, so.
Okay.
So the correct answer is it is indicated for prevention of stroke in non-valvular atrial fibrillation. As was discussed earlier, non-valvular meaning no history of rheumatic mitral stenosis. And then it cannot be used in patients with mechanical heart valves. This is directly from the FDA, their position on the trials. And dabigatran's trial was called the RELY trial. And that showed that dabigatran significantly reduced stroke or systemic embolism and ischemic stroke alone, with similar bleeding complications as warfarin. Rivaroxaban or Xarelto showed similar rates of stroke or embolism and major bleeding versus warfarin, so same. And then apixaban or Eliquis showed significant reductions in stroke or systemic embolism, major bleeding, and mortality compared to warfarin. So this is a little tabular form to show you the doses that should be used. So for Pradaxa or dabigatran, it's 150 milligrams twice a day if your creatinine clearance is greater than 30. If your creatinine clearance drops down to around 15 to 30, it should be 75 twice a day. And then it should be avoided at all costs in anyone with a creatinine clearance of less than 15. As for Xarelto or Rivaroxaban, it's 20 milligrams per day. It's once a day dosing with Xarelto, and that's with a creatinine clearance of greater than 50. If your creatinine clearance is between 15 to 50, it's 15 milligrams a day. And again, avoid if it's less than 15 on your creatinine clearance. While with Eliquis or apixaban, it's 5 milligrams BID, and it's 2.5 milligrams BID if they have 2 or more, and this was also discussed earlier during the Q&A panel. If they have either age greater than 80 years, creatinine is greater than 1.5, or their weight is less than 60 kilograms. If they have 2 or more of those, then you drop down to 2.5 of Eliquis or apixaban. There is actually a reversal agent. This was also hinted upon during the Q&A. There is a reversal agent to dabigatran or Pradaxa, and it's called Praxbind. With that, I think if a person is bleeding, significantly bleeding, I think they go to the emergency room. It's stocked at both ERs in town, actually. where they put an IV in place. They can give you a medicine and it reverses the effects of Pradaxa within minutes. Yes?
Is there an upper age limit for Pradaxa?
No. And then there's reversal agents for Xarelto and Eliquis are actually in the pipeline later this year. And then there's certain things that you need to avoid. Again, the one thing that you should be aware of is verapamil and diltiazem should be avoided with Xarelto and with Pradaxa. Next. And then the monitoring is also important. So if a person comes to you and they're already on these medicines, how do you monitor it? Because with Coumadin or warfarin, we always got an INR, and you check that every so often to make sure that they're therapeutic. With these, they just take it and their blood is thin. But the way to monitor it is to get a baseline creatinine clearance every 6 months at least. So with your twice yearly blood tests, just make sure that their creatinine clearance is holding steady and that they're on the correct dose of the aforementioned medication.
Okay, I wish we had this because I would have hoped that I would like to see the responses of this. Exercise and diet will lower your LDL cholesterol. Okay, the answer is false. Remember that exercise will raise your HDL, but exercise will not lower your LDL. Exercise raises the HDL, but will not lower your LDL unless the patient loses a significant amount of weight with it. Weight loss will lower your LDL, but exercise alone will not lower your LDL. Diet will definitely lower your LDL. So diet lowers the LDL, exercises raise the HDL. And that's why it's important for patients to understand. Patients come in all the time and say, you know what, I'm going to exercise and give it a shot. And I'll tell them, unless you diet, it's not going to happen because exercise is not going to lower the LDL. Okay?
A 49-year-old man with cirrhosis secondary to hepatitis C presents with hypertension. He's on cimetidine, multivitamin, and hydroxyzine. Which one of the following beta blockers would be preferred in this patient? A, labetalol, B, atenolol, C, propranolol, or D, metoprolol? And as you noted, I did not put in the medication that Dr. Mendy had mentioned, which was... hopefully you all remembered Cardiovascular. So the answer actually is atenolol. And the key here is to note that the patient has cirrhosis, has hepatitis C. So all those other medicines, labetalol, propranolol, and metoprolol, are all metabolized via the liver. Atenolol is renally excreted. So it is safer to use in that instance in a patient who has liver dysfunction or hepatic dysfunction.
Okay. Man, I had my questions to trick you guys, but I don't have the response system with me. Okay, a 74-year-old smoker complains of buttock and hip pain while walking. There are days he is pain-free. A bruise is heard on the left femoral artery. The right ankle brachial index is 1.1 and the left ankle brachial index is 0.8. Which of the following is the most appropriate management? Gosh, I missed the response system. Okay. The answer is initiate atorvastatin. Let me go back to the question so I can... The answer is in the history. It says, there are days he is pain-free. Intermittent claudication from PAD, the patient will have pain every time he walks. And every time he walks, he can usually predict when the pain will start, after 2 blocks or after goes to the mailbox. He won't have days where he is pain-free. But if you have spinal stenosis, then there are some days where you can walk 1 block, some days 5 blocks, some days you have no pain. So if he says some days are better than other days, then obviously it's his back. But the choice is he still has vascular disease. His ABI is 0.8 and he's got a bruise, so he still has vascular disease. I gave a lecture at Georgetown University, and this is, and I'm going to tell you what I said there. This is not to knock some of the physicians in Reading. There was a conference at Georgetown University, and they wanted a vascular surgeon's perspective, an interventional radiologist's perspective, and an interventional cardiologist's perspective. I was fortunate to be the last one to speak, so they couldn't rebut. I showed 3 slides. One slide I showed was an arrow from the freeway that says one way only. And I said, when you send a patient to a vascular surgeon, there's only one mind, surgery. And then I showed a sign that had a U-turn. And I said, when you send the patient to the radiologist, they'll do an ABI and they'll send you something that says, recommend an ultrasound. When you do the ultrasound, they'll say, recommend CT angiography. When you do CT angiography, they'll say, recommend an interventional radiologist. And then I showed a sign of all the freeways, a junction of all the freeways in Los Angeles, going in every direction. I said, if you send the patient to the cardiologist, he'll look at the vasculature, he'll look at the carotids, he'll check the cholesterol, he'll make sure the blood pressure is controlled, he'll talk about risk factor modification, and this is true. I've had patients referred for PAD, and they've had bypass before they PAD or carotid endarterectomy before they PAD, and vice versa. Patients who have I had a patient just a few weeks ago, she even had a back surgery, and she had a totally common iliac occlusion. By examining her, we stented her iliac artery, and she says for the first time in 7 years she can walk. So the cardiologist looks at everything, and this patient here needs a statin. The ankle brachial index is only 0.8. So I told you earlier, it's not bad. They need to walk, as Dr. Mufti told you. And walking is better than stents and angioplasty. Now, Celestazol or Platol, remember, if the ejection fraction is less than 40% or they have heart failure, you cannot use. And it's only used to help walking distance. It helps them walk a little further pain-free. But I see patients coming in a wheelchair and on a nursing home on Celestazol. It doesn't help, only helps walking distance. And then those that use Trentol or pentoxifylline, it's placebo. It really doesn't do anything. So if you're going to use Celestazol. Oh, what happened there? This thing is all off. Are you guys moving it up there?
Yeah, we're back. We get back to the response.
Okay, I'll hold. Okay, I'll hold on.
There you go.
Okay, can you go back
Back one.
one slide, please? That's it. Go back to the question. All right, now the next.
No. Yeah.
Okay, one more.
All right. Which one of the following statements is true regarding the management of hypertension? Increasing doses of thiazide diuretics leads to improved BP lowering. Increasing doses of thiazide diuretics leads to more hyperkalemia. C. Increasing doses of thiazide diuretics leads to more hypokalemia. Or D. Increasing doses of thiazide diuretics is not associated with changes in serum magnesium levels.
It'll be one. The next one will be the response.
Okay, no problem.
All right. Well, they already saw the answer, so. So, correct answer is increasing doses of thiazide diuretics leads to more hypokalemia. So, the more you increase, as was mentioned before, hydrochlorothiazide, 12.5 milligrams. If you increase it to 25 versus 50 or even 100 milligrams, you're not going to get much reduction in your blood pressure from the initial dose that you were on. You're actually going to cause more hypokalemia, hypomagnesemia. So if they're on a dose, it should be 12.5 or 25 at most, not higher than that, because you're not going to achieve any greater further reduction. And the better diuretic to use, as mentioned before, based on the study that Dr. Mendy alluded to, which was the all-hat study, is chlorthalidone.
So this is important. You know, you're going to get all your antihypertensive effect with 12.5. You're going to get it all. You're really not going to get any more benefit by increasing the dose. The other thing Dr. Mendy said, which was also heard in a recent discussion on hypertension, that if you use two diuretics, hydrochlorothiazide 12.5 and aldactone 12.5, they almost balance each other out with the potassium levels and you get better blood pressure control. Okay, a 52-year-old woman has a 5-centimeter abdominal aneurysm. You recommend refer for aneurysm repair, refer for repair when size reaches 5.5, repeat abdominal ultrasound in 6 months, change amlodipine to metoprolol. I think the guys in the back are trying to help. All right, let me go to the answer since it's not working. Okay, so it is working. So the answer here is 3. Let me go back. Repeat abdominal ultrasound in 6 months. Women have a higher rate of AAA rupture, and therefore recommended that they should be referred for repair at 5 centimeters. What is important here is that if your aneurysm grows at more than 0.5 centimeters in 6 months, or 1 centimeter in a year, that is telling you that there's instability of the aortic wall and there's impending rupture. Remember that an aneurysm grows at about 0.3 centimeters a year. So if a patient comes in with an aneurysm of 4 and wants to know, when is it going to be needed to be repaired, if it's a female, you know that every year it's going to be 0.3, 0.3, 0.3. So if it's 4, it's going to take about 3 years to reach to 5. So 0.3 a year is the average growth. But if it grows more than 0.6 in 6 months or 1 centimeter in a year, that patient should be referred for evaluation.
Which one of the following statins is not lipophilic? A, simvastatin, B, atorvastatin, C, fluvastatin, D, lovastatin, or E, rosuvastatin. Back on. It was an impossible mission for you to get it back on, right, Ted?
Oh, it's too damn late. We're done.
All right. So you responded with all across the board. So a major percentage of you chose 5. So let's see. The correct answer is rosuvastatin. So the two statins which are lipophilic are rosuvastatin or Crestor and pravastatin. And those are the two statins which are actually, both are not extensively metabolized by the CYP3 A4 mechanism in the liver. So these are the two statins that if a patient complains at times that they may have statin-induced myopathy, these are the two that you should preferentially use. Obviously, if they need high-intensity statin therapy, you go with rosuvastatin, as Dr. Khan had mentioned. It's rosuvastatin or it's atorvastatin. However, if they're intermediate risk, low risk, then you can use pravastatin in its place.
Okay. A 46-year-old man comes to the emergency room with left facial and left upper extremity numbness and weakness that resolves in 1 hour. He takes no medication. MRI confirms a small right ischemic stroke. Echocardiogram confirms a PFO with a right to left shunt with cough and Valsalva. Which of the following is the most appropriate treatment? Aspirin, PFO closure device, warfarin. Okay, so most people recommend a closure device. PFOs are not uncommon. 25 to 30% of us have PFOs. So it's very common. If this patient obviously has a cryptogenic stroke from the PFO, aspirin is the first line therapy. There is no evidence that using a closure device is better than aspirin in somebody who has had a cryptogenic stroke. Warfarin is only used if they have recurrent strokes. So if somebody has recurrent strokes from a PFO, then you use warfarin. And then only after recurrent strokes with warfarin you can consider a closure device. But the randomized trials have failed to show that it is any better than aspirin. Now, if you put a patient on a treadmill and the patient desaturates and gets short of breath and the oxygen level drops, that'll tell you that with exercise they're shunting a lot of blood from the right side to the left side through the PFO. And that's the patient you can consider a closure device, only if they desaturate with exercise. Otherwise, aspirin is the first line of treatment. Why this thing is...
Which one of the following medications has not been shown to improve mortality in patients with systolic dysfunction or heart failure with reduced ejection fraction? A, an ACE inhibitor. B, spironolactone. C, loop diuretics. D, beta blockers. Or E, angiotensin receptor blockers, or ARBs. Yeah. All right.
Okay, so we obviously have to look at a better response system than we have.
All right. So 52% of you had the correct answer. So it is loop diuretics. Now, if you come to the treatment of heart failure or systolic heart failure with reduced ejection fraction, it's a stage C. and can be in New York Heart Association class 1 to 4. And this is directly from the guidelines as well. So a class 1 indication is for an ACE or an ARB and a beta blocker, and preferably, as I mentioned before in one of the first questions of this talk, was the beta blockers to be used are, again, carvedilol, metoprolol, succinate, or bisoprolol. And then after they're on that, then you go, if you can see, it's a class 1 level of evidence C for loop diuretics. Loop diuretics are only there to help with the symptoms of volume overload. They do not change your morbidity, they do not change your mortality. If patients are persistently symptomatic and they're African American, then you add hydralazine and nitrates. Otherwise, the class 1 level of evidence A is for an aldosterone antagonist, or aldactone, or eplerenone can be also used. And those are as indicated per the guidelines. So loop diuretics only help the symptoms, do not help anything with the morbidity, mortality. So this shows you the benefit of beta blockers, ACE inhibitors, and ARBs. As you can see, your reduction in mortality, relative risk reduction in mortality, is greatest with a beta blocker or hydralazine and nitrate. And then the number needed to treat, if you just look at the beta blocker and the aldosterone antagonist. 6 for the aldosterone antagonist, 9 for your beta blocker. And then what it's coming to these days with CMS, the way things are moving, as David Knor alluded to in the first lecture, reduction in heart failure hospitalizations, because that's where it's all going to. So your reduction in heart failure hospitalizations occurs most commonly with your ACE inhibitor, your beta blocker, and your aldosterone antagonist.
Okay. A 76-year-old smoker, status post right carotid endarterectomy 6 years ago. The left carotid is occluded. A follow-up ultrasound now reveals a 90% restenosis of the right, confirmed by CT angiography. The left carotid remains occluded. Which of the following is the best management option? Okay. Refer for carotid stent. Some very important points to be made here. Number one, if an ultrasound shows that a carotid is 100% occluded, that's the time I'm going to recommend that you get a CT angiography to confirm it. Don't just accept it by ultrasound. I recently had a patient, I was told this in multiple lectures, and I recently had a patient where the carotid was occluded and he stroked on the side that the ultrasound said was occluded. So if an ultrasound says it's occluded, confirm it. Number two, if the ultrasound says it is severe stenosis, my recommendation is get a CT angiogram to confirm it. I've had patients who were on the surgical floor for carotid endarterectomy, but they were deemed high risk, and I was called to put in a stent. When we did the angiogram, it was only 30 to 40% stenosis. So if the patient was not high risk, that patient would have had a carotid endarterectomy. This has happened on multiple occasions. And even at UC Davis, I was there at a lecture, and even there the experts recommended dual imaging to be sure. So once you confirm it, then you proceed with surgery. Now, There are two indications why this patient should have a stent. Number one, if you have surgery already on one carotid and it restenosis, stenting is preferred on that one. Number two, if you have one side that's occluded and the other side has a severe blockage, that other side should undergo stenting and not surgery. Once one side is occluded and the other side is severe, carotid stenting is recommended. And then after that, anybody you think is high risk, bad COPD, heart failure, ejection fraction of less than 40%. So patients who are considered high risk should also undergo carotid artery stenting. So some important clinical points here. And I think we have just one more.
Quick question though.
Yes.
Wouldn't you initiate Plavix first?
Sure, absolutely. Absolutely. My preference is to initiate both aspirin and Plavix before I place a stent. All right, patients with paroxysmal atrial fibrillation have the same stroke risk as compared to patients with permanent atrial fibrillation. True or false? The answer is true. If you have AFib once in a while versus AFib all the time, your risk of a stroke is the same. So those patients should be on anticoagulation. And remember again that we do not use the CHAD score anymore. We use the CHADS-2 VASC score. If the patient's score is 2 or more, those patients need to be on anticoagulation. Just one other point about bridging, because this has come up. If you have a patient that you're going to interrupt anticoagulation because let's say they have to have surgery, the simplest way to remember it is 2, 4, 6. You stop it for 2 days for minor procedures and 4 days for major procedures. If the creatinine clearance is less than 50, then you stop it for 4 days for minor procedures and 6 days for major procedures. That's an easy way to remember it, 2, 4, 6. Now the other day, a patient had to interrupt his anticoagulation for surgery, and I recommended that the patient be bridged with Lovenox. And I received some resistance to that, because there was a study called the Bridge study that said there was no significant benefit. But the Bridge study had patients who had a CHADS-VASc score of 2. The mean CHADS-VASc score was 2.3. Some of them were 1. Those are low-risk patients. So if the patient has a CHADS-VASc score of 4 or 5, I have seen patients whom I have interrupted anticoagulation that have stroked while waiting, and it's not uncommon. So if they're high risk, it is better to bridge them with Lovenox and then resume the anticoagulation the day after surgery. Yes?
Is the 246 the same for warfarin as with the other agents?
No. Warfarin, the INR can vary. I have a patient who needs a carotid stent. He needs a pacemaker. We stopped his anticoagulation Monday last week. And on Thursday, we checked the level and it was still 1.7. So that's very individual. It varies. Herbs, foods, so many things interfere with the INR. So that needs to be monitored, and we recommend an INR closer to normal. But that's just for the novel anticoagulants. Any other questions? Yes?
I just had a comment on the choice of beta blocker in cirrhotic patients and the HC question. I think that should be stratified based on whether they have or don't have varices or repeated or average PCRP for varices.
Correct. Propranolol, yes, yes. So the question Dr. Singh was mentioning was patients who have varices or do not have varices, and they're cirrhotic, and for those patients, propranolol is the one that is recommended to be used. That is correct, but that is obviously in that case. If they do not have varices, then that question was mainly because the patient was on cimetidine and other things that would make them higher metabolizers from the liver, and therefore atenolol was the correct choice on that question. Any other questions?
Well, I apologize for the patient response system, but we have hors d'oeuvres. Thank you very much. Please complete your evaluations and you'll get your CME certificate.